Aloha, everybody. My name is Tana Lepule. I am the liaison to our Native Hawaiian Pacific Islander communities here at APPEAL. I definitely want to say thank you for everybody making time, especially to our speakers here, which I'll get into more details on who's supporting this. The name of our webinar, and it's the first of many webinars to come up with regards to data disaggregation. The title is Why Data Disaggregation Matters, the invisible story of Native Hawaiians and Pacific Islanders. We have a wonderful group of speakers today that will address the many levels of how we're making efforts to not be invisible. And hopefully you'll also see opportunities where you, the participants out there, can definitely help and assist in that effort. Again, my name is Tana Lepule. I hail here from the Kumeyaay Brothers and Sisters land. And I welcome you all from the native lands that you folks are attending in. And I just want to jump right into kind of the overview and objectives that we hope to cover. The first is to inform how data disaggregation can reveal greater health disparities facing Native Hawaiian Pacific Islander communities, to provide a broad overview of the impact of data of the Native Hawaiian Pacific Islander communities, and to describe successful examples of data disaggregation in the Native Hawaiian and Pacific Islander communities. Our speakers will be covering those various levels, but I also encourage you to insert questions. But without that, we cannot move forward and without recognizing the support that we're also getting in making this happen. I want to first highlight our host, and we're very blessed to have each of our hosts actually are the actual presenters for today. And the first is the Empowering Pacific Islander Communities, the Oregon Pacific Islander Coalition, the Utah Pacific Islander Health Coalition, and the Native Hawaiian and Pacific Islander Data Policy Lab at the UCLA Center for Health Policy Research. Again, you see it on your screens there. I also want to cover just briefly and get right into the work of our speakers here. Just some housekeeping information. This is a webinar. Our agenda here is a layout webinar. Housekeeping rules is, this is Zoom, so please be mindful of putting mute, but also be very active in participating in the chat rooms or chat sessions. We'd love to get some of those questions and informations. Thank you. The webinar format, Zoom, call your video mic, make sure your video and mic is off throughout the entire webinar. Ask your questions to the speakers by clicking the Q&A icon. If you have any other comments to the speakers, please drop those in the chat box. If you have any technical questions, our technical support team, Priya, Josh, and Jess will be able to assist you. The webinar will be recorded and be posted on designated program websites for the participants to view. Thank you for your participation, and we really hope that this is meaningful. And please reach out to not only myself, but folks on this webinar series to assist in the efforts of our communities. With that, I'm going to go ahead and kick us off. The format will be, with regards to the order of speakers, we'll have someone from the Native Hawaiian Pacific Islander Community Data Policy Lab. Then we'll have two representatives to speak from the community level, and then also another of our speaker, the last of our speakers to speak on efforts at the national level. With that, I'm going to go ahead and kick it off with our introductions, and then we'll start our program. Okay, for the first presenter, Richard Calvin Chang is a Native Hawaiian attorney whose grandmother came from Grace family in Kailua Kona. He co-founded and currently serves as the data analytics director of the UCLA Center for Health Policy Research's Native Hawaiian and Pacific Islander Data Policy Lab, and was appointed to the Census Bureau's National Advisory Committee this year. Calvin has managed policy campaigns that address data equity, health equities, and improved representation of Native Hawaiians and Pacific Islander in data-driven policy. He also co-authored and led the development of the first demographics profiles of Native Hawaiian Pacific Islanders in the US and California. He currently works to aim and to raise awareness of COVID-19's importance, disproportionate impact on Native Hawaiians and Pacific Islanders. He is currently pursuing his MS in Computational Analysis and Public Policy from the University of Chicago. I welcome Calvin Chang.
Thank you very much for that introduction, Tana. Yes, and thank you to APPEAL and Rod Liu for inviting the NHPI Data Policy Lab to present on this panel. And I'd also like to acknowledge all of the efforts that our elders put into making sure that we had access to data in the first place, especially those of Calvin Chang, who unfortunately passed away recently in Southern California, who was one of my mentors who convinced me to continue on this track of continuing to advocate for our community's data. And I would also like to thank the members of the NHPI Data Policy Lab for supporting the work that I am able to do because of them. Next slide, please. Our community has had to fight tirelessly for data that other communities take for granted. What we see on the slide before us are 5 states that unfortunately are not currently disaggregating NHPI COVID-19 data. And the reason that these 5 states are being shown to you is because they represent half of the top 10 states ranked by NHPI population, alone or in combination, using the latest 2020 census data. So half of the top 10 states representing our community's population is unfortunately not even present in the data, or is being merged with other larger categories such as Asian. As you can see, the Arizona Department of Health Services in their dashboard utilizes the Asian or Pacific Islander definition when they're reporting that category. And it's unfortunate because we know that a lot of these states actually have access to more disaggregated data, but this is what's public facing. This is what's easily accessible. And this is the resource in terms of their state dashboard that many of our organizations turn to when they need access to the most recent data. And it just places an extra burden if they have to sift through the CDC data portal in order to pull up their state or their county's disaggregated NHPI data. And this is extremely problematic because from what we found, majority of the states that are reporting NHPI COVID-19 data has found that NHPIs have the highest case rate and the highest death rate of any racial or ethnic group. We can only imagine what might be hiding in the states that are not reporting our data. Next slide, please. So what we're seeing here represents a number of states that are disaggregating different types of COVID-19 data. Over the course of the pandemic, we've seen states continuously change and their dashboards evolve over time. But unfortunately, what really hasn't changed is the fact that our community's data is not being reported for these types of COVID-19 data in approximately half of the states in our country. And just to make that point, this is data that was actually scraped last night. So this is fairly recent. There's no real reason why the NHPI community should have such a low figure, especially when compared to other major racial and ethnic categories that the federal government mandates data collection for in OMB 15. And while I understand that states may not necessarily be required to comply with a federal mandate geared towards federal agencies, these are states that have received federal funding to deal with COVID and to address equity issues around COVID. There's clearly a lot of work that needs to be done in terms of convincing these states of the importance of making sure that our community is represented in the data, since that data is also what's used to prioritize COVID-19 relief services and to make sure that there are culturally appropriate and linguistically tailored programs that can conduct outreach and education for our communities. Next slide, please. What we're seeing here is that even when the data is available, unfortunately, there are severe issues with data quality. To take California as one example, the California Department of Public Health recently reached out to our data policy lab because they realized that the rates that they're seeing for vaccinated NHPIs was certainly unusually high, to say the least. And the number of NHPIs who received at least one dose, that's data that was pulled from 2 days ago. And the vaccination rate was calculated using the Census Bureau's 2019 ACS one-year population estimates. And California, they do allow NHPIs and the California population 12 years and older to be eligible to receive a vaccine. This is just a quick and dirty calculation that was made using census data that was required because the California Department of Public Health and the counties you see below it on this table haven't actually released the population estimates that they are using to currently estimate our vaccination rate. We found that at least California, LA, and Orange County have been using proprietary data from third-party services for their population estimates. And we are currently still working to find out what that population estimate might be. And it's greatly concerning to us because those estimates may severely undercount our community, which might end up revealing a vaccination rate that is far lower than what people are actually seeing. It's terribly misleading. And we actually had been reached out to by a reporter in Sacramento who wanted to know what the secret was of being able to convince our community to become vaccinated at such a high rate. And it was pretty sobering to have to explain that from what we're hearing on the ground, at least from these counties, these vaccination rates are not realistic. There's an asterisk next to the Orange County vaccination rate because according to the population estimate that the Orange County's health department is relying on, what they're seeing is a vaccination rate that's in excess of 100%. Next slide, please. So some of the solutions that we think need to be considered, at least from the 30,000-foot view, is that racial and ethnic data categories need to be standardized across the country. At a very minimum, states receiving federal funding should be utilizing the OMB categories at a minimum. But what we've seen from data from Hawaii and California is that many of the states that contain a lot of our smaller communities need to go even further in making sure that other subgroups within the NHPI umbrella are disaggregated. And that's because we found that this past winter, especially when we were going through the winter surge, the vast majority of COVID-19 cases and deaths were coming from non-Hawaiian Pacific Islander communities. And that's important to know because those are the communities that disproportionately do not speak English at home and may not have access to healthcare services to the extent that US citizens do. So we need even more detailed categories than the broader OMB 15 major categories. We also need to make sure that even if we are collecting disaggregated data, that disaggregated data needs to be reported, especially in public-facing data dashboards. We've seen disaggregated data from counties within Arizona that show up in the CDC's provisional de-identified patient data set. And so we know that a lot of these states do have access to disaggregated data, but for some reason are not reporting our category in their dashboards. And I think we need to standardize multiracial categories. The Native Hawaiian community has a much greater proportion of multiracial individuals than other racial and ethnic groups. And what we're seeing is that it has a major effect on the denominator used to calculate a lot of our rates. When you include multiracial Native Hawaiians, oftentimes the size of our population, or the NHPI population, doubles. We also need to improve data quality. What we're seeing from the vaccination rates is that it may not just be a matter of having the incorrect population estimate as a denominator. There may be other communities that are unfortunately misreporting as NHPIs. And lastly, we hope that the agencies that are in attendance will continue to engage with the community to resolve these issues. Next slide. Thank you very much for this opportunity to present.
Thank you very much, Calvin, for sharing that perspective from specifically, institutions that can help in this and assist in this work. Thank you for raising the issue of just the invisibility, but then when there is visibility on how important it is to collect clean and responsible data collection. So thank you very much. I want to go ahead and go into our next speaker. That is Alyshia Alohalani Macaysa-Feracot, is a Kanaka Maoli Filipina Health Equity Strategist and the founding executive director of Oregon Pacific Islander Coalition. The heart of her work is integrating a decolonized public health practice into community-led racial equity initiatives. This journey has led her to work across community development, public health, and technology sectors. Alicia is a Multnomah County Public Health Advisory Board member, a Health Equity Committee member for the Governor's Racial Justice Council, and a nationally recognized culture of health leader through the Robert Wood Johnson Foundation. Ladies and gentlemen, I want to introduce you to Alicia.
Mahalo, Tana, and thank you to the APPEAL team for having me and to Calvin for his presentation. Like Tana named, my name is Alyshia Alohalani Macaysa-Feracot. My pronouns are she, her, hers, and I'm joining you from the occupied lands of the Multnomah, Wasco, Cowlitz, Claflamet, Clackamas, bands of Chinook, Tualatin, Kalapuya, Molalla, and many other tribes who made their homes along the Columbia River. So like Tana was sharing, I'm going to really be speaking from kind of this grassroots community organizing level. So I wanted to start off by just talking about why does data disaggregation matter for Native Hawaiians and Pacific Islanders? And I think there was a ton in there that Calvin has already shared. And we certainly see those struggles in Oregon of over-reporting on vaccination rates and a lack of integrity in the data. But what I want folks to understand that it's about more than data disaggregation for our community. And it's about more than just being represented in racial and ethnic categories for these different health outcomes. For us at OPIC, it's about decolonizing data. And so that means decentering white folks as the beacon of good health and seeing our communities like from this kind of deficits-based role and saying, oh, how can we get them to be more like these other populations? We want to move away from that, right? It's about also grounding our solutions to systemic health inequities in the preservation of culture and ensuring that Pacific Islander values and leaders and researchers really lead and own the work. Because I think too often aggregate data really just obscures or erases our needs or our stories altogether. It really fails to capture the strength of our communities and our cultures. And it oftentimes really prevents investments and resources from getting directly to Pacific Islanders. And I consistently say in my work, Pacific Islanders know how to serve Pacific Islanders best, but we can't do that without the resources to function, right? And so a lack of disaggregated data ultimately really undermines our expertise, our abilities, our culture, and our strengths, and of course, our self-determination. And those things are so key when it comes to serving Pacific Islanders. So we can go to the next slide. So let's talk about this, right? How can disaggregated data lead to better solutions? Well, in 2019, we had the chance to work with Multnomah County. And when I say we, I mean the broader Pacific Islander community. So we had the opportunity to work with Multnomah County on what we called the Pacific Islander Data Project. It was led by Dr. Eileen Duldalau and Miss Virginia Luca. And the idea was not just to disaggregate Pacific Islander health outcomes from the larger API category, but also have Pacific Islanders set the entire framework for the project and have it really be led by community. So with the data justice framework, right, not just disaggregating the data, but really thinking about shifting powers, shifting frameworks, we did things a little differently, right? So usually, for example, one of the things that our community wanted to talk about was birth outcomes. We actually have a lot of doulas and traditional health workers in our community. And so, usually when you're reporting out on birth outcomes, what you see is the percentage of low birth weights, the percentage of maternal mortality. And we wanted to flip that model on its head. Instead, what we did was, well, let's report the healthy birth weights. And so what you'll see is 92% of our COFA folks, for example, had babies who were born at healthy birth weights. And so by flipping the data and framing it in that way, instead of getting into conversations with our community, right, about like, oh, well, what are y'all doing wrong? Why are 8% of your babies born at low birth weights, which again is still an important example. Instead, what we wanted to do is say, well, what's going right for those 92% of folks? The other interesting thing that we ended up seeing was when we disaggregated the data, even within the Pacific Islander category, right? So I don't have a more broken down visual here, but what you'll see is, for our COFA folks, and specifically within our COFA folks, we looked at data on adequate prenatal care and early prenatal care access for Palauan birthers specifically. And, they were around like 30% of them had about like adequate access to prenatal care. So we expected that the healthy birth weights would be a much lower number too, because only 30% of a population, that's a pretty small number, right? And by disaggregating that data, we got to get into more thoughtful conversations with them where we said, well, like a lot of y'all aren't accessing early prenatal care. And most of the time, these Western frameworks tell us that, well, your babies, your babies are more likely to be born at a low birth weight, but that's not the data that we're seeing. So what's going on here? And it was interesting, right? It led us to this conversation with the Palauan birthing community where they said, well, yeah, we may not be accessing Western systems of care, like, for example, going to Kaiser Permanente to have a prenatal appointment, but we do have a system and care embedded in our community, right? Where we are taking care of one another, organizing food drives, pooling like mutual aid and money so that the person who's pregnant doesn't have to overstress and, work more hours than their body needs to while they're carrying a child. There's all these different things going on in the community. And so again, it led us to this really interesting conversation of, well, what would it look like to invest in that? And certainly healthcare access is still really important, but also are there solutions that we're missing when the data doesn't help us highlight the nuances and the strengths of what it means to be a Pacific Islander person who's part of a much broader community? And so we can go to the next slide here. And thanks to the folks fielding questions in the chat for me. So, taking on that project, we also wanted to say, okay, well, what would it look like to expand that effort and what's really possible? And, with my short amount of time left, what I'm here to say is that doing this work from a data justice framework is very much possible. We're doing it here in Oregon, and I'm really excited about what we're doing. I think it's important to note that, one, we actually have in 2015, Oregon Health Authority did create standards about how to disaggregate data. And we have like about 35 different racial and ethnic categories. In July of just this past summer, we also had the Data Justice Act pass out of Oregon legislature, which requires disaggregated data by our private health systems. But what I want to really emphasize here is that one of the things that we've been doing is also the Pacific Islander data modernization work. So just so folks know, we have Oregon, like many other states, implements the BRFIS, the Behavioral Risk Factor Surveillance Survey. But we have been essentially rendered invisible in that data set, despite how significant it is in policy and planning. And so over 3 years of intentional racial and ethnic oversampling, and the Oregon Health Authority was only able to collect 106 responses from Pacific Islanders in the entire state of Oregon. And essentially that data set was so small that it wasn't really usable in other data projects for our community. The other issue and critique here is that it doesn't really tell an accurate story of what our community is struggling with and what's possible for our community. And so again, this data modernization work just really emphasizes the importance of community-led research. And so when the health authority approached us as a coalition and said, okay, the BRFIS data isn't working, we need to do something else, we need to serve Pacific Islanders better, we really got to lead. How are we going to collect data? What questions are we even going to be asking? How can we get all of our different leaders involved in this work so that they see themselves in this research? Surely representation isn't like the only metric of success, but I am proud to say that when we did this work through our community networks, well, it took the state 3 years to engage 106 Pacific Islanders. It took our community 6 weeks to engage over 150 Pacific Islanders. And this is just one, I'm just showing one of the many visuals that are part of this report that just got released in the last few months. The other thing I'll name in terms of action we're taking around data disaggregation is now that we have the information in Oregon that tells us that community connections is absolutely critical for Pacific Islanders, we're starting to match our funding to reflect that, right? So for example, Oregon just passed ballot measure 108, which is a tobacco tax, and we're projecting about $20 million in revenue. Well, if we know that community-centered work is especially important to Pacific Islanders who, as you see on this chart here, like historically haven't had access to these major systems of care, how can we match, a funding proposal to actually resource community-based organizations? And so rather than steering all of these investments, this $20 million towards, major institutions or major organizations that aren't really connected or serving Pacific Islanders, we're really trying to do work to say, can we create a request for proposals for this $20 million that gives room to fund and sustain Pacific Islander work? So including the ability to ask for the salary of a full-time person. And if we know that, especially in tobacco work, how important BRFIS and chronic disease data is, but Pacific Islanders aren't adequately represented in that data, how can we use more community-centered data systems and data sets to really help inform like what kind of strategies or interventions we want to invest in? So that's work that's currently in progress, but all of that was possible because here at Oregon, our folks are really understanding what the importance of disaggregated data is. So I could go on and on about it, but I'll pause here because I'm excited to hear both Jake and Sina speak as well. But that's just a little snippet of what we're doing in Oregon.
Thank you very much, Alicia. Again, another example of some of the groundwork that our communities are doing, an opportunity to hear the examples, but also some samples of how that partnering with communities can work at the multiple level, whether it's locally, state, local health departments, or even within the communities that we plan to work with. So with that, I want to go ahead and introduce our next speaker. Jake Fitisemanu was born in New Zealand, Aotearoa to Karen Dang from Kaimuki, Oahu, Hawaii, and Jacob Fitisemanu Sr., Falefa, Upolu, Samoa, and raised in Hawaii and Utah. Jake holds a master's degree in public health from Westminster College and has led public health programs for the Utah Department of Health for 9 years. He was appointed by President Obama to the President's Advisory Commission on Asian Americans and Pacific Islanders in 2015, and was also the Utah Pacific Islander Health was also appointed to the U.S. Census National Advisory Committee for 2 terms. Jake has chaired the Utah Pacific Islander Health Coalition since 2011, sits on the Huntsman Cancer Center Institute Community Advisory Board, and directs the Samoana Integrated Language Initiative. He lives with his wife and 2 daughters in West Valley City, where he serves as a member of the City Council and chair of the Healthy West Valley Initiative. I introduce to you, Jake Fitisemanu.
Talo falava everyone. Mua lava mamoli atu ai le nganga whawhitai mo nei avanoa. O te whatalo whatu malo uava, malo ufa alu alu tele lava. It's a pleasure for me to be here with you all this afternoon And I've enjoyed learning from my colleagues and previous presenters more on this topic. And I hope to just talk story a little bit about some of the work that we've been able to do here in Utah, very similar to the really inspirational work that's being done in Oregon that was just discussed, and maybe give a little bit of nuance in the way that we've been able to do things here, in that Utah is a different state politically in terms of our state agencies, our legislative makeup, et cetera, than other states, which might be considered more quote unquote liberal there on the West Coast or in other big metropolitan areas. And so if I'm able to inject or help shed a little bit of light, maybe for some of you who are from other states or other communities where the politics, where words like health equity and restorative justice and social justice may not even be in the lexicon in a lot of civic spaces. If we can do it here in Utah, I'm pretty sure it can be done anywhere. And so I'm going to share a screen here briefly and just show a couple of examples of some of the things that we've been working on. Of course, there's always room for improvement and collaboration, and hope that this will be useful for our discussion today. So tell me if you see a screen here with a lot of words that starts with chronic diseases and conditions. I hope that's, I'm trying to work off two screens here. Okay, I bring this up. This is a screenshot from 2005 health report here in Utah. I'll blow it up. And I'm starting with this because this was before the time when this is when Asians and Pacific Islanders were still being combined, at least here in Utah, in a lot of our health indicator reports. And I wanted to bring up two issues. One, starting here with diabetes. It talks about the prevalence of diabetes among American Indian and Alaska Native folks, as well as Hispanic Latino populations, adult populations. Interestingly enough, Pacific Islanders are not here. Although every year since there have been disaggregated data available, Pacific Islanders have led the state rates. And so this is to the theme and to what Tana had introduced at the very beginning, invisibility in terms of data and in terms of representation. Because of the aggregated status at this time, invisibility was huge, and we just did not know, even if anecdotally and in the community, we knew what was going on. But it was not reflected in the data, just like Alicia had mentioned, because we were not being captured in the BRFSS and other surveys, and we were still being categorized together. And with a community, at least here in Utah, with Asian Americans having very, very low diabetes rate, mixing in Pacific Islanders with that high rate, there was that skewing of the data, and it was essentially statistically invisible. Another example down here, and again, I know you folks are very familiar with these. When we look at coronary heart disease death rates, the statement here is that Utah's Asian/Pacific Islander populations had lower rates of death from coronary heart disease than the state overall. Looking at this in the years that we have disaggregated data, it's very easy to show that there's a large discrepancy and disparity between Asian Americans and Pacific Islanders. And so again, combining them into one category was not helping. It was statistically erasing those disparities from the data. And so what ended up happening once we did get a couple of rounds of BRFSS, and it was very, very noticeable that Pacific Islanders were number one in a lot of areas that we would prefer not to be. In 2011, this report was put together. It was an oversampling very similar to the one Alicia works on in Oregon, in that there were, in 2010, the year before this was released, there were only 61 Pacific Islanders captured in the regular BRFSS or BRFS methodology. With the oversampling, we were able to get funding and allocate this to an oversampling that within a couple of months reached over 600 Pacific Islanders, and that's completed responses, which means we reached a ton of people who didn't complete the responses either. But this ended up being compiled into this report, which was specific to Pacific Islanders, which for the data nerds in the room, talk about p-values and confidence intervals and all of that. It was amazing. It was great. You all know, if you're doing research on Pacific Islanders and we're looking at different disparities, there's always, when you see that NHPI, there's always a dot or an asterisk or a dash or some kind of a statistical note that says, yeah, this data is not great. Sample size was inadequate, or you may want to look at, further research to get some better data. Very, very frustrating. But being able to do that and see those disparities and discrepancies, we were able to continue with additional reports, including a 15-year longitudinal report that was released in 2016. And with that data, we're also able to dive even further into different geographies within the state of Utah to look into those discrepancies even further by health district or geographic. And so with the couple minutes that I've got, I just want to share a really neat intervention that came about. As Alicia mentioned, we had some very similar to Oregon, Utah, our Pacific Islander data was showing some really dismal rates in terms of prenatal care, the lowest rates in the state. And when we looked into that, again, because of different cultural practices and midwifery and those type of things, we wanted to get to know that a little bit better. The sad part was, unlike in Oregon, our data matched very, very closely with infant death, with infant mortality and birth defects, and also maternal adverse outcomes. And so in our particular case, those numbers were also the worst in the state, and we really wanted to be able to address that. As Alicia also mentioned, we were adamant that we didn't want to center clinical Western, quote unquote, white methodologies and clinical outreach. And so we, because of disaggregated data that then revealed these disparities, we were able to actually put together community collaborations and build a program which we call It Takes a Village. And it's a community program. And so really it starts with a framework that is based in cultural practice. And then we put in the clinical or clinical guideline pieces. It's centered into a funnel type of a format that sets up groups, which could be church groups, it could be family groups, it could be peer groups, whatever it was. We had halal participate as cultural performing groups. We've had families get together and do this, and over the years, we've been able to hone it and find ways to make it even more effective. And so we frame this within specific concepts like the funnel or the village council, about VA or these family relationships and sacred space. And each one includes videos there with people from the community discussing these issues. When it comes to the clinical guidelines, they're Pacific Islander physicians and nurses who are talking to our people from a perspective that's relatable with our people. And all the resources that are provided there that are really tailored to that. And so this is one that's actually been published and is being recognized by a national organization as best practice or promising practice. And it's here on this website. We want it to be available. It's been adopted by other health departments in other states as well. Again, it's just a model, and it's just one example of a model that, again, because of statistical invisibility, we probably would not have even known, even though in the community, anecdotally, we definitely suspected that infant mortality was an issue. And anyone, we actually even worked with some funeral services here who were, are puzzled by how many Pacific Islander infant funerals or memorial services they've been asked to do, and how to work with communities and how to engage with families. And we're able to do that through a cultural lens rather than a sterile or a more clinical lens, I guess you could call that. And so again, this, if I had time, I would be able to go on and on about our community gardening project, which came about as well because of disparities data around nutrition security and access to fruits and vegetables. as well as our diabetes and obesity outreach programs, not to mention our COVID-19 response programs, which we demand, I'll use that word demand, special reports from the local counties as well as the state to provide information that's not provided on the general website for general knowledge because our community is so small. We're asking for direct points of contact for a specific epidemiologist in the health department to be designated as our point of contact to provide us with the granular information that we need, not just the public facing data for COVID-19. And that's a model that we are going to be adamant in implementing for all chronic health conditions and for any other health conditions as well moving forward, now that we've got that connection and see how powerful that can be to have someone on the inside working that data. And so I think that's my time, but I just wanted to share this one model of it takes a village and kind of do that background trip back into time to when we didn't have that disaggregated data and how detrimental that was. Moving forward, as Alicia and Calvin mentioned, it's not just about getting acknowledged, it's not just about being represented in the data, but it's about making that data meaningful and putting it into action and implementing changes for our communities. So thank you very much.
Thank you very much, Jake. Again, to everybody out there, you just heard two examples from the community level of how communities are doing the work. It's not that there isn't work being done, but I think there are opportunities here where we can replicate some of these interventions. Our speakers will be available. We will submit, if you need to get a hold of folks, we can definitely share that. But if our speakers also don't mind sharing your emails on the chat for folks to have direct contact to follow up with any of those wonderful programs that you're doing at the local level. With that, I'm going to go ahead and introduce our final speaker, which is Sina Uipi, is the Policy Associate for Empowering Pacific Islander Communities, or APPEAL, who leads its national advocacy and policy work. APPEAL is a national Native Hawaiian and Pacific Islander organization that is pro-Black, pro-Indigenous, and pro-LGBTQ, based in Tongva Territory in Los Angeles, California. As the DC-based staff, she is housed at the National Council of Asian Pacific Americans, or NCAPA, a coalition of 37 national Asian American, Native Hawaiian, and Pacific Islander organizations. In her current role, she advocates for Native Hawaiian and Pacific Islander issues such as health, education, immigration, civil rights, housing, and economic justice. She also supports in managing NCAPA's health and policy committees. Sina recently completed a fellowship program where she strengthened her leadership development and skills known as Community in the Capital, hosted by and facilitated by one of APPEAL's partners, National Capacity. Ladies and gentlemen, I'll introduce you to Sina Uipi.
Thank you, Tana, and thank you everyone for having me. I really want to commend my fellow panelists for all the work that they're all doing, because it really does, without the work that they're doing and many of our other Pacific Islander partners and coalitions across the country, it wouldn't be possible to make sure that we have, a national voice. And so I really commend the work that they're all doing. I just really wanted to just kind of touch base on, data disaggregation at the federal level and what that looks like currently for not only APPEAL, but just Native Hawaiians and Pacific Islanders as a whole, and just some of the efforts that we've been doing. Just kind of giving one example is because of COVID, the information that Calvin had presented earlier with the NHPI Data Policy Lab, that really helped us in advocating across the board with federal agencies, with Congress, with engaging with the White House about the gaps that really exist in the data that the lack of data that exists at the federal level when it comes to COVID. And so just something that I wanted to share was that in the beginning of this year, President Biden had, there was an executive order on advancing racial equity and support for underserved communities through the federal government. So under this executive order, there was a equity data working group that was created. And so that was kind of like our entry point in partnership with our national coalition and CAPA, the National Council of Asian Pacific Americans, to make sure that we really not only identify the gaps that exist for data disaggregation in all federal agencies, but also to make recommendations as well. So some of the things that that we've done so far was that we had sent a letter recently to the Equity Data Working Group and just really just kind of outline some of the things that that we would like to see come out of the working group, but also you know, really take into consideration the recommendations that we provided. And so some of the things, some of those things include, you know, like, especially when it comes to sharing, you know, with not only the agencies, within the agencies, or within just Congress, when it does come to specific legislation, but really to make sure that there's transparency that is very open to the community as well. So one of our asks was that we asked that they share more substantive updates regarding the design, scope, and limitations and implementation of data disaggregation efforts across federal agencies. And we were really intentional about our engagement with the administration of expressing how critical data disaggregation is, not only for the Asian American communities, but for the NHPI communities as well. Some of the things that we recommended was that we had asked them to prioritize the disaggregation of COVID-19 data in order to understand and respond to the needs and health disparities within our communities that have emerged since the onset of the pandemic. And some of that, you know, it includes resolving incomplete federal data on the impact of COVID-19 on specific NHPI communities, and resolving discrepancies between federal data and data collected by local, state, and non-government entities. Some other points that we had made was that we asked for them to create or update a federal minimum standard for data collection across all relevant agencies. I know for the federal minimum standard should also expand collection for NHPI subpopulations, which included Native Hawaiian, Samoan, Chamorro, Tongan, Itaukei, Marshallese, and other Pacific Islander. The 2020 census listed the following checkbox options for Native Hawaiians and Pacific Islanders, which included Native Hawaiian, Samoan, Chamorro, and the write-in section named Tongan, Fijian, and Marshallese as explicitly suggested subcategories. Another point we made was that we asked to create pilot program or pilot programs or incentivize agencies to expand their current data collection categories for NHPIs beyond the newly created federal minimum standard, and ensure adequate discretionary funding to all federal agencies to meet this new requirement. In addition to the process of data collection, you know, we really want to make sure that they ensure the inclusion and disaggregation of Asian American, Native Hawaiian, and Pacific Islander populations, as well as the inclusion of community and scientific expert voices in all stages of federal statistical data collection, including its design and development, collection, compilation, processing, analysis, dissemination, and preservation. And there was another request or recommendation to create and support a scientific advisory committee and a community advisory committee on data equity, similar to the structure adopted by the U.S. Census Bureau with significant representation by Native Hawaiians and Pacific Islanders. So these are just a few things that we recommended in the letter that we recently sent, but also it's really about making sure that we engage, not just with this working group, but also making sure that we are still continuing engagement and conversations with all of the agencies, especially through the Department of Health and Human Services, and also really through Congress is what I've tried to advocate a lot of, not only our data or the need for our data, but really our stories as well. Especially during the pandemic, there's been multiple hearings, congressional committee hearings on COVID, and I almost never see any information or any updates on NHPIs. And so that's always like, an entry point for us to make sure that we are speaking with those committees and those congressional offices that, are still learning about our communities, and also making sure that it's consistent, with making sure that we are not only informing them, but also, to see how that shows up in legislation, how that shows up in this equity data working group, but also through the White House as well. And this is just one, we're just one piece of a larger puzzle. I know many of my colleagues, and especially my fellow panelists here who are really doing the work on the ground, is helping to make sure that those stories are told also at the national level. So those are just some things that I wanted to share. And I think one thing that is really key to this, I think, is just being consistent, right? In engaging with these different agencies, because, data disaggregation has been a long time priority for many of our organizations and for many of our communities. And so this is just us continuing the work. So thank you again for having me.
Thank you, Sina, for sharing some of that effort at the national levels and how it actually relates to some of the local efforts. I want to also thank all of our speakers, again, for covering a pretty broad spectrum when it comes to invisibility, but also some of the work that we're doing to kind of help make our communities visible. And I do see that there are some questions in here. I want to make some time for that. I see we have some short time remaining. But I want to go ahead and, if it's okay, I want to direct some of these questions to our speakers here. First, if I can pose this to Jake, how can organizations leverage the successes of Utah's interventions in the states where APIs are still in aggregated category?
Yep. I think one of the initial challenges that we had here in the state of Utah was just about building vocabulary with our policymakers. And so that involved going to the Hill, that involved meeting with legislators, that involved speaking in committees and hearings at our state capitol, as well as really developing great partnerships in some of the powerhouses of public health and clinical health throughout the state, our big healthcare systems, our health insurance providers, others who also believe, at least nominally, in the need for more granular data. Some of these agencies need that because they're trying to watch their bottom line. Others like that data because they're really trying to help individuals and communities that are the most impacted or the most marginalized, who I don't really care what their motives are. Well, I do, but in the end, if they're interested in engaging in that conversation and helping us move those conversations to tables where policies are being made and into the offices of our policy makers and legislators, for example, that's how we start to really build the vocabulary so that folks are more comfortable talking about this and realizing that, especially in a state like Utah, where folks talk a lot about, fiscal conservatism, et cetera, showing folks how this makes the most bang for buck when it comes to our taxpayer money and serving the people who really need to be served. And so building that vocabulary, I would say, is a lesson that helps right up front, as well as being able to leverage powerful partners and collaborators in the healthcare, public health sectors and beyond, and show that disaggregated data doesn't just help in health, but also has great applications for improving outcomes and making systems more effective and efficient in human services, in education, in every other sector as well. So I think those are great things to build vocabulary, to get great partners and collaborators, and then also be able to extrapolate that and show the impact that that will have across the state in various sectors.
Thank you. Again, in sticking to the folks on the ground, I want to pose this to Alicia, and that is, why is community leadership important when it comes to data and research for Native Hawaiian and Pacific Islanders?
Yeah, mahalo, Tana. I think it goes with even what Jake was saying in the work he was highlighting of, like, you look at the data, right? The official data that a state or an institution gives out, but what's missing there is there's already a ton of community data and information, right? And without the community's leadership and involvement, we would not know that those stories really exist. And, again, there's a ton of information and wisdom already there. And in Oregon, we're trying to talk about it as these community data systems, right? So what would it look like to merge community data systems with what the state knows or doesn't know, or what a health system knows or doesn't know? I think the other important thing to understand is, like, we can build all of these different interventions and strategies to address health issues for Pacific Islanders or for any community of color, for example. But like some of the work that I was doing for, like, the broader immigrant and refugee community in Portland was, we had health clinics, we had affordable housing available, but if a community did not see themselves represented in that structure or institution, they were less likely to actually access that thing. So even if they had a health clinic, in their immediate neighborhood, they were driving 2 hours away to go to a health clinic that was recommended to them by, someone trusted, like a sister or a family member who said, no, this is the doctor you need to see. And all of those things are really important to understand from communities who have never really felt served or seen the benefit of, different health interventions and health strategies. So always centering community in the work that we do is just so important. And I think goes back again to what Jake was highlighting of how do we also be effective and efficient with the resources that we're investing. It starts with community.
Thank you. I'm a firm believer of that too. And to institutions and academia, I think we show some good examples of how that works, and even how the Data Policy Lab has come into play and how that works in balancing national efforts. As a closing sentence question, and I appreciate everybody for staying on as long as we can, and we'll follow up with questions that continue to come in through our email. But closing one is to the Data Policy Lab. How can other community partners or academic institutions or institutions itself partner with Native Hawaiians and Pacific Islanders to address data issues?
I think that's an excellent question, especially having come from working on the ground for about 10 years before moving under UCLA's wing, and the opportunity to connect with the community has been fantastic, given that we've we started working under the UCLA Center for Health Policy Research, which has partnered with community organizations in the past, but has shown itself to be even more willing to work more closely and understand some of the cultural nuances that our community requires if we are to get their buy-in when it comes to some of our projects. So what I've learned is that these institutions, particularly academic institutions, really need to start building relationships with those who are on the ground before a pandemic hits or before an economic crash hits. We shouldn't be trying to build this airplane while it's in the air. What we've seen is that when institutions take the time to build these relationships with the community beforehand, these relationships become something you can turn to very quickly to make sure that the community gets the data and access to researchers that they need much more quickly. So building those relationships beforehand makes a huge difference, but also being open to community-based participatory research principles, making sure that community is a part of not just implementing a project or a grant, but also making sure that the community is part of the process before even applying for the grant, to make sure that community leaders are invited to the table when those proposals are structured in the first place, to make sure that there is a benefit to the community and not just to academics or researchers who may just simply get to pad their resume with more publications. It really is about making sure that door is open from the beginning and remains open through the grant proposal process, through the implementation, through the evaluation phase that occurs afterwards.
Thank you very much, Calvin. And also I want to give a big thanks, if we could all give some virtual appreciations to our speakers today. Also to our speakers who are also co-hosts, which is OPIC, UPIC, EPIC, and our Native Hawaiian Data Policy Lab. I definitely appreciate all the support. This cannot happen without that, as our co-hosts and also as speakers, but also our Asian Pacific Islander partners for empowerment and leadership, with Rod and his leadership to provide space for us to operate here. And then also with CDC and the Office of Smoking and Health and the Division of Cancer. A lot of this involves partnerships, support, and uplifting of each other. And with that, this is the first of many series, other webinars that to come. Please keep an eye out. Evaluation is also very key when it comes to data. So if we could practice some of those behaviors and keep an eye out for an email with regards to a survey, evaluations from Linda, we definitely appreciate that. And we'll do our due diligence in trying to get to the rest of the questions that did come up, and we'll get that out to everybody. But with that, again, much alofas from myself and my fellow colleagues here for this opportunity. Hopefully it's a resource, but at the same time, if there are resources out there to help continue to uplift this effort, please contact us. Our information can be available. With that, we thank you very much. And to our speakers, any 1 to 2 second closing remarks? No, we're good? Okay, well, I know it's all love that's coming from our speakers also. And again, thank you very much to everybody for your participation. And I believe this is recorded and will be shared. So thank you very much, everybody. Have a wonderful day.
Mahalo, everyone.